everyone, welcome back to my channel Dental Cafe. Today I am going to discuss about the pulp therapy in pediatric dentistry. It is very important topic because clinical questions come from this topic in competitive exam. Okay, then let's begin the video. Pulp therapy in pediatric dentistry can be divided into vital pulp therapy and non-vital pulp therapy. Under vital pulp therapy we have pulp capping, direct and indirect pulpotomy, epexogenesis. Under non-vital pulp therapy, we have pulpectomy, non-vital pulpotomy, apexification. Begin with vital pulp therapy. Okay, first one is indirect pulp capping. What is indirect pulp capping? It is a procedure which involves a tooth with a deep carious lesion where carious dentine removal is left incomplete and decay process is treated with biocompatible material for some time in order to avoid pulp tissue exposure. Look at the figure. Grey shaded area or black shaded area represents deep carious lesion. You can very well see in image that it is approaching the pulp or close to the pulp. That is why indirect pulp capping is under vital pulp therapy, because carious lesion is close to pulp but not involving it, so pulp is remain vital. Technique of indirect pulp capping. It usually takes 2 appointments to complete. So firstly we will discuss what all procedures we have to perform under first appointment. Perform under local anesthesia and isolation with rubber dam. Look at the figure. This is deep carious lesion. So we remove the majority of soft necrotic dentine with slow speed handpiece using large round burr. This is the first step. After that, periapical carious dentine is removed with sharp spoon excavator. This is second step, and now the final cavity outline is achieved. This is the final cavity outline that we have to achieve after removal of carious dentine. We have to remove only infected dentine, not affected dentine. The left carious portion is the affected dentine, which is close to the pulp, is not removed. Only infected dentine is removed. This is the third step. After that, what we have to do? Cavity is flushed with saline water and dried with cotton pellet. We have to dry the cavity with the help of cotton pellet. As we know, the left carious portion is the affected dentine. Over this we'll apply calcium hydroxide layer, or we can say site is covered with calcium hydroxide. This is the fifth step that we'll do. After that, zinc oxide eugenol is applied and the remainder of the cavity is filled with zinc oxide eugenol cement. It will act as base, and over this temporary restoration is done. After 6 to 8 weeks, we will recall the patient and check for the formation of predentine or reparative dentine. Look at the figure. Remove temporary filling material, zinc oxide eugenol and calcium hydroxide. We will notice the following changes. Previous remaining carious dentine will become dried out, flaky and easily removed. So we'll remove that portion of dentine, and area around the potential exposure will appear whitish, which is predentine. This is very important point. This is predentine or reparative dentine. Then again we'll wash out the cavity and dry it gently, as we can see in figure. Then cover the entire floor with calcium hydroxide. Then base is built up with reinforced ZOE cement or glass ionomer cement, and this time final restoration is placed. This is the complete procedure for indirect pulp capping. Indications of indirect pulp capping. Firstly, judge that minimal and complete removal of caries would cause pulp exposure. Mild pain associated with eating, negative history of spontaneous or extreme pain, and no mobility of tooth. then only we'll proceed for IPC, and when pulp inflammation is nominal. Then other indications: layer of affected dentin after removal of infected dentin, normal lamina dura and periodontal ligament space, no radiolucency in the bone around the apices of the roots or infolcation, deep carious lesion which are close to but not involving the pulp in vital primary or young permanent teeth. Contraindications of IPC: any sign of pulpal or periapical pathology, soft leathery dentine covering a very large area of cavity in non-restorable tooth, sharp penetrating pulpagia indicating acute pulpal inflammation or prolonged night pain. Other contraindications: mobility of tooth, discoloration of tooth, negative reaction of electric pulp testing, definitive pulp exposure, interrupted or broken lamina dura, radiolucency about the apices of tooth. Now I'll discuss very important topic, that is difference between infected and affected dentine. Look at the figure. This dark brown shaded area represents infected dentine, and area around the infected dentine is affected dentine. Why it is called affected dentine? Because it is affected by bacterial toxin released from infected dentine. That is why it is affected dentine. Infected dentine is highly demineralized, unremineralizable, superficial layer lacking sensation, and stained by 0.5% fusion or 1% acid red solution. Affected dentine intermediately demineralized, remineralizable, deeper layer sensitive, does not stain. Now we are talking about ultrastructure. Intertubular dentine greatly demineralized with irregular crystal, deteriorated collagen fiber that have only distinct crossbands, no interbands, and should be excavated. In affected dentine, intertubular dentine is partially demineralized with bound apatite crystal, distinct crossbands and interbands, and should be left remineralized. Don't forget to subscribe my YouTube channel and hit the bell icon for the latest videos.